Hey guys, Dr. Ben Weitz here with the Rational Wellness Podcast. Each week I'll be bringing you the latest cutting edge information about health and nutrition. In this media-driven world, it's easy to be confused about what's true and what's not. I'll cut through the conflicting headlines to bring you clarity to help you optimize your health and maximize your life. Subscribe to the Rational Wellness Podcast on iTunes, Stitcher, or YouTube. Let's get started on your path to better health.
Hope was so enticing back in the day. This crazy new thing just finding its way and we all.
Hi, Rational Wellness podcasters. Happy to have you join us again today. Our focus today is going to be on prevention of cardiovascular disease. And so this is a very exciting topic because cardiovascular disease is still the leading killer of Americans. So when we look at cardiovascular disease, we're talking about trying to prevent heart attacks and strokes. And when conventional cardiologists look at this topic, they're typically measuring serum levels of cholesterol, LDL cholesterol, which is the so-called bad cholesterol, and HDL cholesterol, which is a good cholesterol. And then typically, if LDL cholesterol is elevated, they'll be prescribing medications to reduce cholesterol, typically statin drugs, but then there's a whole series of other drugs, including some newer drugs. And however, when you look at primary prevention, the research that really backs up the benefits of taking these statin drugs is very weak. So primary prevention is trying to prevent in somebody who, say, has elevated cholesterol but otherwise has no symptoms and is otherwise healthy, trying to prevent them from having a heart attack or stroke. And then we have secondary prevention, which is when somebody has already had a cardiovascular event like a heart attack or has evidence of pre-existing plaque in their arteries. And for secondary prevention, statin drugs actually have some more proven efficacy. However, as a functional medicine practitioner like myself, we want to look at why is it that these plaques are forming in the first place, these cholesterol plaques, that then can lead to occlusion of the arteries and heart attacks or strokes. And so from looking at why the body is laying down these plaques, it turns out it's actually a very rational response of the body to either inflammation or oxidation or glycation, which can damage the inside of the arteries. So the body is rationally laying down this coating, which is a cholesterol plaque, to protect the arteries. So therefore, rather than simply looking at cholesterol levels, because keep in mind, even if you don't ingest a lot of cholesterol, the body can produce its own cholesterol. Let's look at what is causing the inflammation, the oxidation, the glycation that stimulates the body to lay down these cholesterol plaques. So from a functional medicine perspective, when we work up a patient, we're going to look at some of the underlying causes, such as chronic infection, issues with the gastrointestinal tract that can lead to inflammation in the gut, that can lead to bacterial endotoxins being secreted that create inflammation. We're going to look at toxins, heavy metals, as well as other causes of inflammation. And if we can intervene and correct these underlying causes of oxidation and inflammation, we can potentially reduce the creation of these cholesterol plaques. And it's a much better root cause way of looking at these cardiovascular issues. So today we have a very special guest, my friend, Dr. Howard Elkin, and he's a board-certified cardiologist. He's also an anti-aging specialist. And Howard also is going to be releasing a new book on anti-aging sometime next year. And he sent me a couple of advanced copies of it, and I can say from what I've read, it's going to be a really exciting book. So, Howard, thanks for joining us today.
My pleasure.
Okay. So, what is your perspective on cholesterol? You know, conventional cardiologists typically look at cholesterol as the cause of heart disease. And this has been questioned in recent years. And LDL cholesterol is often considered the target, but Dr. Stephen Sinatra and Johnny Bowden, in their book, The Great Cholesterol Myth, have examined whether or not LDL is really the cause of heart disease or just an innocent bystander. And a quote from that book is, "By putting all of our attention on cholesterol, we virtually ignored the real causes of heart disease, which are inflammation, oxidation, sugar, and stress." And they go on to explain that until LDL particles get oxidized, they're really not a problem. What's your perspective on this?
Well, you said a mouthful right there. And just off the bat, 50% of people that have heart attacks then have normal cholesterol levels.
Okay.
So it's just one piece of the pie.
Right.
I think one of the reasons why it's garnered so much attention over the years is because it's easy to measure. It's something measurable, like blood pressure.
Right.
It's just, so it's one important piece of the pie, but LDL cholesterol, which I call the lousy cholesterol, that's what people know it as, it's just, again, it's not some bad, horrific thing. In fact, LDL cholesterol, there's HDL, which is thought to be the good one that brings cholesterol back to the liver, that it can be disposed of, excess cholesterol. LDL brings it away from the liver, where it's produced, to the various sites where it's needed. Well, we necessarily don't need it in our arteries, but we definitely do need it in our brains. So, just off the bat, LDL cholesterol isn't as lousy as it's purported to be. My perspective is, like you say, it's just a number, and it does tell me some information, but there's so much more than just what the LDL cholesterol is or what the total cholesterol is. And if you look at a typical cholesterol panel done by either your internist, your primary care doctor, or your cardiologist, you're going to do total cholesterol, HDL cholesterol, triglycerides, and the LDL cholesterol, which is a calculated value. So that really doesn't give us nearly much information if you're really talking about prevention,
Right.
especially primary prevention.
Right. Great. So we're looking at an advanced lipid profile such as the Berkeley Heart Labs profile or the VAPP that actually calculates an exact number of LDL particles and looks at particle size as well as other factors like inflammation and homocysteine. Is that an important thing to do?
Absolutely. I do a lot of those panels. As you know, Berkeley Heart Lab was the premier cardiac lab for many, many years. It was bought out a few years ago by Quest Labs, which in a way made it very good because Quest is the largest lab, I think, in the country, if not the world. So you go to any Quest lab and get this blood work drawn. And it's a great panel because it tells us, besides the things that I mentioned before, it tells us the size of the LDL particle, the particle number and the size.
Right.
And we can talk about the size in a minute. It also gives us the inflammatory profile.
Right.
There's at least 3 different inflammatory markers that come to my mind right off the bat. Then it gives us metabolic factors, which is an important part in assessing risk, and then also a few genetic tests.
Right.
So it's really taking all that into consideration when we assess someone's risk.
Right, great. When dealing with LDL particles, what do you have a specific thought about what number of LDL particles and the importance of the size versus the particle number?
I prefer the LDL particle size. It gives me more information. If the LDL is elevated, the LDL particle number is going to be elevated. So that's a given. But personally, I like looking at the size because first of all, there's a small dense particle size, and there's large buoyant, or what you call large fluffy particles. Well, larger is better, and it's more protective. Small dense is more likely to get oxidized and get incorporated into the artery wall and cause plaque. And we're talking about a 40% increased chance of oxidation.
Right.
So it really makes a difference. So yes, I want to measure the size of the particle, and different labs do it differently.
Right.
But that's really what interests me, because the treatment and the diet is completely different.
Right. And it's also important for the HDL particles. If the HDL particles are larger size,
Right.
then they're more protective,
Absolutely.
right?
The larger the particle size with HDL. So if you remember nothing else, the important thing I tell people is that larger is better, bigger is better. You want your LDL and your HDL to be big. If you remember nothing else,
Right.
remember that.
Yeah. In fact, we've had a number of patients who had like extremely high HDL, and then it turns out it's not actually the favorable size, so it's not as protected.
Right.
So another reason why it's really important to get an advanced lipid profile
Absolutely.
rather than just relying on a
If
standard.
you don't know it by getting a standard panel, oh, HDL 80, that looks great, right? Well, then you go ahead to the subclassification, you find out that it's mostly a smaller particle size, which
Right.
doesn't really confer much benefit
Right.
or protection.
Because the larger size does what's called reverse cholesterol transport, right? So it actually is taking the bad LDL cholesterol particles and removing them from the bloodstream.
Right.
So when treating a patient that's at risk for heart disease, because let's say they have the small dense LDL particles, do you start with medications? Do you start with diet? How do you approach those patients?
It's a great question. I always try not to start with medications unless it's so off the wall, crazy high. Because it's when you start a patient with medication, it's like you're telling them, okay, we know you can't do this on your own. We know you're not going to change your lifestyle. So why don't we just give you medication?
Right.
So to me, it's disempowering what a person can do.
Right.
So I let them know, okay, this is your risk. You know, let's see what you could do. And I'm like you. I have a nutritionist that works with me.
Right.
So between the two of us, we spend a lot of time on diet and exercise and stress management and anything dealing with prevention.
Right.
And then if 2-3 months go by and we're not getting anywhere, then we will consider other avenues. There are also certain supplements that we can talk about. And then, so that's kind of like
How much time is needed for nutritional interventions to work? Is 2-3 months enough? Because
It's
like sometimes it
yeah.
can take a little bit.
It also, let's backtrack a little bit. It also depends on what I see. If they truly, let's say they have small particle size,
Right.
okay, and they're diabetic. That's like a double whammy.
Okay.
Then I might intervene, but I'll use niacin. And niacin is actually a vitamin. It's vitamin B3. It's a B vitamin. Now we use it in a larger dose than you would take as a supplement. But so I do intervene sometimes depending on what the risk factor profile is. So diabetic, that's a red flag. If they have heart disease, that's a red flag. And if they have a small particle size, that's a red
Right.
flag. But 3 months is probably not completely adequate, but it gives me an idea.
To see if they're trending in the right
Right.
direction.
Because, and then I'm going to find out what have you been doing? What is your exercise regimen like? How have you changed your diet? And you can pretty much tell in that period of time where they're really trying.
Right. What do you think are some of the most important dietary factors to change or add or modify?
Good question. Well, it's not about cutting out adding some saturated fat. That was, for years. I mean, American people who might remember from the 90s, we were, talking about the AHA, American Heart Association diet,
Right.
the Dean Ornish diet. And then, so that basically that was a very high carb, low fat diet. But the thing about it, back in the 90s, we didn't really know much about particle size. And I questioned that diet from the very beginning, but it's like, well, one size can't possibly fit all.
Right.
So my way of thinking, and people like Dr. Sinatra, we're pretty much in accordance with, and I know you are too, that cholesterol and fat is not really our major villain here. It's probably sugar, because sugar is very pro-inflammatory. We know that coronary disease, like cancer, like autoimmune disorders, like Alzheimer's, all four of those biggies, they are the diseases of aging, but they're inflammatory processes. So sugar is the most inflammatory thing we can ingest. I tell people it's like pouring gasoline over fire.
Right.
So we have an internal furnace going on. So my emphasis is different. I try and get people off starch and
So when
fried
you say
grains.
sugar, you mean not just sugar, but high glycemic carbohydrates, like chips and bagels and breakfast cereals that are going to spike your sugar
Pastas.
as well. Pasta,
Right.
bread, rice, chips.
Which is not the typical the cardiologist, well, is going to tell, oh, stop your fat, or you're fat, or don't eat meat. that was really old-fashioned thinking. There's more and more coming out now in the literature, as you know, Ben, that saturated fat maybe isn't the great villain we thought it was. In fact, now they're thinking saturated fat can actually has a role in increasing the particle size of the LDL. And that's a good thing. It may also increase HDL. So
Kellogg's cereal is not a way to cure heart disease?
no. It's not good for the heart, it's not good for the brain. You know. So it's like, it's a total turnaround because this is exactly, you know, a contradistinction to what we were taught. You know, and I've been here long enough to see the whole change. And, you know, you and I know this, and I think, I wish more, you know, the hope is that will mainstream cardiology get it, you know?
Right.
And that's what my hope is.
Right. It's starting to filter down, but it seems to take a decade for the truth, the leading edge nutritional stuff to actually filter down into the conventional medical community.
Absolutely. So I think what you and I are doing by educating the public and getting them involved,
Right.
that's my whole thing. My book is based on how you can become your own medical advocate. Well, it's by pulling in the reins and,
Right.
you know, and being informed and go to doctors and healthcare professionals that think prevention.
Right. And the ones who do still, a lot of the conventional ones are still telling patients to simply reduce your level of saturated fat.
Right. And that's really being questioned now. I mean, I have pulled like 2 or 3 articles in the last 6 weeks that contradict that old way of thinking. We
Right.
have to be ready to accept new thinking.
Right.
You know, it's not like cutting back the saturated fat really made a major difference in the incidence of heart disease.
Right.
You know, like you said from the very beginning, there's a lot more than the picture than just cholesterol.
I saw one of your recent blogs when you were commenting on one of the new PCSK9 inhibitor drugs, specifically the one from Amgen known as Repatha. And what do you think about these drugs? And do you want to comment about
Sure.
that article?
I love talking about this. First of all, this is a new class of drugs. They're called PCSK9 inhibitors. Don't ask me what that stands for. It's very long. But these are biologics. Okay, they're administered subcutaneously through injections. So what they do, and these 2 drugs, by the way, came out within 6 weeks of one another, and they basically are very similar. They attach to the, it's actually a monoclonal antibody. So it's an antibody that attaches to this PCSK9, which is a receptor site in the liver that produces cholesterol. And the long and short, without getting terribly complicated, is that it affects the receptor in such a way that cholesterol can't be released. You know,
Right.
less is being released in the circulation. It's a very complicated pathway, but less is released, and it's dramatic. I mean, you can see an LDL cholesterol reduction at 55-65%. Okay, but we really don't have outcome studies yet. The blog that you're speaking of is that they took, this was recently reported in American Heart Meetings earlier this month, and they took patients, they added a statin, they added the PCSK9 inhibitor to the statin. They got like LDL levels of, I think the average was 37. Now, and the authors are like, wow, this is really good. 37, how low can we go?
Right.
And those of us that think not in that narrow box, outside the box, because we know that LDL is not some horrible thing, you need it for the brain, adequate brain function. We're questioning how useful, how good is that?
You need it
And are
for
we
the brain.
suffering?
We need cholesterol for hormone production, for estrogen and progesterone,
Vitamin D.
So there's a range
Absolutely.
of
So
important
I'm like you, I'm fearful of that. And you gotta remember, these drugs, $14,000 a year. It's very, very expensive. And I don't see the price going down. All biologics tend to be very high. They have to be administered, via injection. So it's nice to have drugs like this in as part of your armamentarium for very difficult patients, patients that have very high levels of LDL cholesterol, that have heart disease and diabetes and so forth. But it really needs to be restricted to a very small subset. The average person out there should not need to go on this medication. It's my
You see, I think, Howard, you're missing the point. You're overlooking the benefits of the pharmaceutical industry.
Right. I mean, yeah. And I have a few patients on it, like maybe 3 or 4, and just getting them on it is a major hurdle
Right.
with the insurance company. But these patients were statin intolerant, and they really have bona fide serious disease, okay?
Right.
We're not talking primary, we're talking preventing a second,
Right.
or third, or fourth event.
Right.
It's different,
Right.
okay? As a cardiologist, I see a gamut of very ill and people that truly come in because they
Right.
want to practice primary prevention, so.
When you do prescribe statins, do you often put patients on coenzyme Q10 as well?
Always.
Yeah.
First of all, and that's a great question, and this is another, I had to take my anti-aging or fellowship to learn this, because I kept saying, why do people have muscle aches and weakness? No one could tell me. I would ask the drug reps, this is a common complaint already, and it was a known complaint. So when I took my anti-aging medicine, and I met Dr. Stevenson, I said, oh, it's easy. The same pathway the liver uses to make LDL cholesterol is the pathway to make CoQ10. We don't want to inhibit that pathway because every cell in the body, including your muscle cells, needs coenzyme Q10 for energy production. So if the CoQ10 isn't available in the muscle cells, they get weak. And that's a common complaint. So yes, anytime I do use a statin, they always put on coenzyme Q10.
What kind of dosage do you use?
I usually start with 100 milligrams, depending on what if I'm also looking at blood pressure or what their heart function's like. Now, a lot of these patients are also on beta blockers, which is another group of medications that depletes your CoQ10. So I would say 1 to 200 milligrams. Now, the coenzyme Q10 is an extremely useful supplement for heart patients, and I go up to very high doses, but that's in people that have heart failure or heart dysfunction.
Oh, okay.
That's a different subset of patients. So I have a lot of experience with it, and I use it a lot, and it can make a major difference.
So patients who have heart failure, these are essentially patients who their heart is so weak that they're either going to get a heart transplant or they're going to die at some point in the future.
Right.
However, I've spoken to Dr. Mark Houston, and I know that he's had some success in turning these patients around and actually increasing heart function to a point where they don't even need a heart transplant.
Right. And that's where conventional medicine has failed. Like beta blockers and ACE inhibitors and diuretics, et cetera, are very useful in 3 ways with heart failure patients. A, it improves their symptoms. B, it keeps them out of the hospital. And C, it's been shown to improve their longevity. But we aren't dealing with the nutrition. We're not improving their nutritional status. And that's where you need the nutraceuticals. And I explain this to my patients that have heart failure symptoms. You need CoQ10, you need magnesium, you need L-Carnitine, you need D-Ribose,
Yeah.
And you add those 4 together,
Right.
and a patient with heart failure makes a major difference in what activity they can do, their lifestyle.
However, they need a pretty hefty dose, especially if
Yes.
the D-Ribose.
Yeah.
Yeah, sometimes 15 to 20 grams per day.
Yes. So, again, it's funny, I send patients to UCLA or Cedars for a possible transplant, just evaluation. People with very, very, very poor heart function. When the doctors see those supplements, you must be a patient of Elkin. Already have a reputation. That's okay.
Right. Since I know that you use diet and nutritional supplements, maybe you could talk about some of your favorite supplements that you like to use for patients with certain risk factors. Maybe, why don't we start with LDL particle number and size?
Right. Good question. Well, certainly we've already discussed, right off the bat, let's do the HDL. That's the first thing to mind, because everybody wants to know, how do I increase the HDL, which is a good cholesterol? And there's some people that just genetically have a low HDL.
Right.
I've tried everything and I can't get above 35. Usually it's with men, but it's with women too. These tend to be diabetics, but it could be anyone. But I like hefty doses of olive oil. We're talking anywhere from, the studies have shown 2 to 4 tablespoons. I mean, 4 tablespoons could be a much every day, but I think most of us could take 2 tablespoons of olive oil a day, and it needs to be extra virgin olive oil because it's the least processed, and it's high. It's the polyphenols that do it.
Right.
And it's a modest increase, maybe 6 to 8 or 9 milligrams per deciliter, but that's pretty good. If you can go from 35 to 42, that's not bad.
Yeah.
Coconut oil, which has been maligned by cardiologists forever, which is present as saturated fat, has been shown to increase HDL. So those are the 2 things I like in diet. And also low carb diet.
Yeah.
That's another reason why to go low carb. You don't have to go ketogenic, although ketogenic has been very successful in this endeavor, but also just a low carb diet itself. Then of course exercise. It used to be thought that only aerobic exercise increased HDL. Now it's been shown that strength training also has a role, but usually it's high intensity exercise is important. Weight reduction, and definitely smoking cessation is going to be number 1.
Right.
And so that's, and as far as medications, niacin can increase HDL.
Right.
Niacin can, and another class called fibrates, which is that you need a prescription for. But I prefer niacin if I'm trying to really increase HDL. So there are some tools.
Right.
As far as LDL particle size, saturated fat. Again, another thing that's been maligned forever. It's been increasingly shown in recent years that may have a role in increasing the particle size. The other thing is sugar. You got to get rid of the sugar and the starches.
Right.
A low carb diet is going to have an effect on increasing the size. Those are the 2 big things right off the bat. I do use a lot of niacin. Niacin's been very helpful as a supplement to increase LDL particle size.
Right.
Fibrates can be useful as well. So that's kind of what I use.
What about red yeast rice?
Red yeast rice is actually like a progenitor to a statin. I mean, the first statin that came out in the early to mid 80s was Mevacor, lovastatin, and it was derived from the red yeast rice plant. So, it hasn't. I don't think statins have never been shown to be useful in increasing HDL or increasing particle size. So I kind of look at red yeast rice supplement in that way. I don't think it's been studied too much, outside that particular arena. But I do use a lot of it because a lot of patients don't want to go on statins.
Right.
So it's a great thing for a lot of patients. It seems to improve, decreasing LDL. But it won't have much effect on the particle size.
Right. What about some of the other factors that can be found on an advanced lipid profile, like the Lp(a)?
Yeah, Lp(a), very good question. And Lp(a) is a fragment or a particle of the LDL, and it's extremely atherogenic, meaning it's extremely likely to get it's extremely likely to get oxidized. That term oxidation, it's like a nail that gets rusty or an apple that turns brown and when you expose it to air. Think of that happening inside your arteries. Lp(a) is extremely inflammatory and can be easily oxidized, so it's a major risk factor. And statins don't touch it. PCSK9 inhibitors, we don't think touch it either. We don't have experience with that one yet. Right. Niacin can help. Estrogen can help in women. Also combination of certain things like fish oil, and I think you have experience in adding other things. Fish oil can be useful.
Right.
What else? You have other things?
Yeah, we've had some benefit with using berberine, also tocotrienols, which is a type of vitamin E subfactor. Those can be helpful as part of the mix.
And one other thing too, when we talk about cholesterol, most of what we talk about is hyperproduction. If you don't even eat anything with cholesterol in it, your liver will make what you need for life, if not more, depending on your genetics and how the liver processes things. Depends on the receptors and so forth. But also, some people are what we call hyper absorbers. And I've learned that recently because now I've been doing some testing with Boston Heart Lab, and they actually what's called a cholesterol balance test. And they can tell whether you're a hyper absorber or a hyper producer by measuring certain sterols. Very interesting. So there's like berberine. It's a very useful supplement because that can also cut down on cholesterol production in the liver, as well as cholesterol absorption by the gut, and also helps decrease sugar absorption. That's one of my favorite supplements now is berberine. So there's a lot you can do.
What about CRP, which is a measure of inflammation, specifically HS, high sensitivity CRP?
High sensitive C-reactive protein, I measure almost everybody. Even if I'm not doing the sophisticated Berkeley or the Boston Heart Lab test.
And isn't it interesting how rarely it gets measured by conventional doctors?
Yeah.
I get so many panels in, and I always have to send them back for a CRP level. It's hard
It's
to believe
remarkable.
that.
It's not an expensive test. It should be done routinely. To me, it's a major risk factor for not just heart disease, but for anything. So a normal level is less than 1. That's where you want to be, less than 1. So the red flags that come into my mind, if the level is, well, of course it was greater than 1, but if, like obesity, my patients that are obese are going to have levels of 3 to 4. So obesity itself is, abdominal obesity, that's a cesspool of inflammatory molecules right there. We didn't know that. Years ago we thought fat was just fat, it was inert. Not true. It's very metabolically active in a very negative way. It's very inflammatory. Sleep apnea or sleep deprivation is inflammatory. One of the most common sources is the mouth, the oral cavity. So when I see a patient with elevated CRP, I don't know where it's coming from, because it's very sensitive, but it's very non-specific. I'll say, okay, I'll circle the number. I'll say, why don't you bring this to your dentist and ask him or her, is there any possibility that my oral cavity could be a source? If they don't know what you're talking about, it's time to get another dentist. Or go to a periodontist, because it's important that your dentist knows. Because anyone in today should know that there's a correlation between what goes on in the mouth and what goes on in the arteries and inflammation in general. And the other one is sinusitis. That's a big one too. So I'd like to know the source. There's some great anti-inflammatory supplements out there. Fish oil is my very, very, very favorite. Anyone over 40, it will benefit from fish oil. I like turmeric, ginger. We mentioned something else earlier. I forgot what it was. Boswellia.
Yes.
There's several, but again, I want to kind of get to know, if I can, what's the cause. And sometimes I never get to know it. That's very frustrating.
Right.
And I let the patients know that. And that's why it's not a perfect world. So you want them to exercise. You want them to, sleep is very important. I've been doing an informal survey in my office. I don't know if you have. And now I'm asking people, especially my working people, not so much the retired people, but working people, how many hours do they get? Men, it's like 4 to 5 hours a night. Women, it's like 6 to at least 7 hours a night. And I said, maybe there's a reason why women live 7 years longer than men. They get more sleep.
Right. In today's busy society, it's very common that people are.
We're all sleep deprived. We're doing more, so it's pretty crazy.
What level of fish oil do you like to see your patients get?
I use a particular brand, a company that I'm happy with, but, you mean the concentration?
Yeah, how much dosage? Like
I usually like a combination. Okay, good question.
And once a day, twice a day?
Usually, if it's just pure prevention in a healthy person who doesn't have anything going on, I suggest like kind of 1,000 milligrams, combination of EPA, DHA. There's 2 major fish oils,
Right.
EPA and DHA.
Those are the active ingredients in fish oil.
Right. DHEA has been increasingly shown to be DHA, increasingly shown to be important for brain function, heart function, vision, all these things as we get older. They both are very anti-inflammatory. They're both, I think, equally good at that. And EPA has been shown to be useful as far as it's a natural blood thinner, helps prevent blood clots. So if it's a healthy person, at least a gram, which is 1,000 milligrams. If they have any cardiac risk factors, 2 grams, 3 grams. If they have high triglycerides, by the way, the fish oil is very good to lower triglycerides, but they need a big dose, like 6 grams.
Yeah.
And divided doses with meals
Right.
throughout the day. So
Okay.
fish oil is probably, that and CoQ10 are my 2 biggies.
Let's touch on one more factor. How about homocysteine levels? That's an independent cardiovascular risk factor, independent of cholesterol. That's often seen on these advanced lipid profiles.
Right. And most cardiologists don't draw it.
Right.
And if you look at mainstream cardiology, they say, well, there's no proof that treating it really does anything. Again, I think that's because there's no pharmaceutical agents out there to tout, I think it's important because it is a risk factor. We know that elevated levels of homocysteine they are involved with endothelial dysfunction, which is this one cell layer with this. There's a cell lining your arteries called endothelium, one layer of cells. If that gets disrupted, which happens with hypertension and cigarette smoking and homocysteine, then you have an artery that's less than perfect. And then that artery is going to be prone to become inflamed. And that's how, it's not just about cholesterol. That allows cholesterol to happen, so it may be as important. We just don't know that yet. So I measure it in everyone. It's on all these advanced panels. You want to have a level less than 10. And you'd be surprised how common it is. But it's easy to treat. It's B vitamins, B6, B12, and B9, which is folate. And I only use folate, not folic acid, because folic acid is synthetic.
And it's helpful, I think, to use the methyl forms.
Yeah. Right, especially if you do this, and you want to mention about MTHFR?
Sure, yeah.
There's a new test out there. There's a new buzzword in preventative cardiology and preventative health, MTHFR, which stands for methyltetrahydrofolate reductase. It's an enzymatic defect that it's genetic, and it's seen in up to 30-40% of the population. But if that happens, then you are prone to high homocysteine levels. And these people, such individuals, do not do well with folic acid. In fact, they should make sure none of their supplements have folic acid. They should only have folate, and like you say, the methylated form, because they have methylation problems. It's a really important thing now in preventive medicine because such people are prone to depression, gut issues, absorption issues, multiple miscarriages. I'm just learning about it. It's amazing.
And by the way, think about the American society where so much of processed foods, breads, etc., are all
Folic acid.
Yeah, they're all enriched with straight folic acid, and you have 40% of the population that can't utilize it.
Right.
That folic acid can build up and actually cause problems.
Something really should be done about this, and the reason why there's so much folic acid, because what they want to prevent is neural tube defects in pregnant women.
Yes.
Okay, but at what cost? So that's why we try to educate people that say, if it's I had a patient that went to Trader Joe's or Sprouts, one of them, and I said, go through the cereal aisle because if they want to eat cereal, they say, what cereal is healthy? I say, none. And she said, you're right. I went through every single cereal, everything on that on the shelves. There wasn't one thing that didn't have folic acid.
Right.
Yeah, it's true.
That's great. So this has been a great discussion, Howard.
It's been
We've
fun,
covered
yeah.
a lot of topics.
We did.
So if patients or practitioners want to get hold of you, what's the best way to get a hold of you?
Well, my website is www.heartwise.com. That's HEARTWISE.com. We're also on Facebook. And so I'm in Whittier, which is not that far from LA.
What's your phone number?
Oh, thank you. 562-945-3753.
That's great. Thank you, Howard.
All right.
I hope we can have you back when your book comes out next year.
Yes, next year for sure.